Okay, guys, we're gonna cover chapter 3 here. We were supposed to do this the other night. We ran out of time. Rather than keeping you late, I figured we could do it this way. We're gonna try not to do this too often throughout the class, but in a pinch, I think it works. And this is a pretty short chapter, so let's get right through it here. Chapter 3 deals with medical, legal, and ethical issues that you would encounter during the care of patients. Understand that, again, this EMR class is a nationally registered based class, so specific laws are going to have a great deal of variability from state to state. The overwhelming majority of laws that we have to follow are set forth by the Commonwealth of Pennsylvania, and regulations based on those laws are implemented by the Pennsylvania Department of Health's EMS Bureau. So when you're actually functioning after this class, that is kind of whose oversight you're going to fall under. Understand some basic concepts that no matter what we do, the goal is always to do no harm to our patients. That's kind of a basic tenet of medicine across the board. All of your care should be provided in good faith, and we want to provide proper, consistent care, showing compassion, and also maintaining your composure. It's a very underrated and important skill for any EMS provider to have, that we're going to be put into critical situations that are going to be tough for most people to deal with, and we have to rise above the stress and the pressure of the situations we get involved in. So let's talk about duty to act. The duty of act basically is what tells us that if we're dispatched to a call, no matter if it's an accident or somebody that's sick, you have a duty to act. So it's your duty or your job to respond to the scene in a reasonable amount of time, without any inappropriate delays, like stopping at Sheets for a snack or getting a drink. You have to go right to the scene of the call, render emergency medical care within your scope of practice, within your skill set, within your training, and of course using the equipment that you carry on your unit. If you fail to do these things, if you fail to respond and render care, it could leave you personally and your agency vulnerable to legal action. If some harm were to come of your patient, and they wanted to file a complaint, you'd have some issues to deal with. Understand too, just still talking about duty to act, that only applies when you are actually on duty, meaning working for an agency or volunteering for an agency, and you're responding to a call in your coverage area or that you were dispatched to. That does not apply if you're off duty, in your personal vehicle and not responding to calls. There's nothing that says that you have to go out of your way to respond if you are not on duty. So please understand that, and nobody can come after you legally for failing to respond. If you are not on duty, you have no duty to act at that point. Now, whether you believe it's appropriate to act, considering that you'll be a trained person and render care until the appropriately dispatched agencies actually respond to it, is a decision that you personally will have to make. But I want you to understand the legalities of it. All right, so standard of care essentially is talking about the manner in which you are expected to act, perform your job, and your conduct or behavior. So in order to meet a standard of care, you have to treat the patient to the best of your ability. So using all of the skills that you're going to learn throughout this class, all of the knowledge that you're going to cram into your brains as you read and study and take and pass your tests. And you have to provide care that a reasonable, prudent person, somebody with the same training as you, would provide under similar circumstances. So essentially, what any properly trained EMR would provide throughout the state, you have to meet that same standard um, across the board. Your scope of care, or you'll also hear it referred to as your scope of practice, is defined ultimately at the national level by the U.S. Department of Transportation Emergency Medical Responder Education Standards. So that essentially is the curriculum that the National Registry tests to and follows, and it's largely what the EMR scope of practice in Pennsylvania and other states are based off of. Understand, however, that um, there is some variability in what is in the national scope of care, scope of practice, and what is in the Pennsylvania specific scope of practice. We're teaching you in here what is going to be the national standards, but we will also try and highlight when there's some difference between what's being done nationally and what your state scope of practice covers. And there are some differences, and we'll get into those later on throughout the class. This also ties into our standing protocols, and EMRs follow under the basic life support protocols within the state of Pennsylvania Department of Health EMS Bureau, and any standing medical command orders. This also can be covered in the form of online medical direction when you talk over the radio or telephone to a medical command physician at a hospital that has its medical command facility. And all of the local hospitals within the area have that. Lock Haven, Jersey Shore, Mount Nittany, they all have medical direction. Now, one hospital that does not, I guess I was kind of misspoke there, is Bucktail. If any of you guys are up near Renovo, Bucktail is not an approved medical command facility. That doesn't mean that they are not an approved acute emergency room for somebody that you should avoid taking patients to, but understand that that's the closest hospital. They're not going to be a medical command resource for you. You have to contact Lock Haven or one of the other nearby hospitals for medical command from that facility. And it's an issue that I unfortunately run into quite a bit working on the MICU that has to respond up there. So if you guys are up there, please understand that. Treating a patient ethically means doing so in a manner that conforms to accepted professional standards of conduct. So what does that statement mean? It means that you have a job to do. You have a responsibility to stay up to date on any skills and knowledge. And guess what? You're going to learn these skills here in this class. And if you don't keep practicing them, you're going to get rusty. So you absolutely are going to have to occasionally pull out a piece of equipment. You're going to have to review how to use a splint or any other equipment that you have. If you haven't run a cardiac arrest in a while, you should go through and practice running a code. And part of this too is attending continuing education classes. You guys are going to have to, in order to maintain your certification, take Con Ed classes, and that helps you keep your knowledge base up. You're also going to have to participate in quality improvement activities, and that involves actually reviewing the care that you provide and looking for potentially any deficiencies in it and how you guys can improve the care that you're providing. You may find that for whatever reason your service is not following the spinal immobilization protocol as it should, and you're missing applying cervical collars to patients that you should be. That should come out of your department's quality improvement review, and you should then go ahead and do some additional education in that area to make sure that you guys are doing what you need to do to take appropriate care of your patients. Ethical behavior requires honesty, so there's no room for lying. There's no room for being inaccurate or intentionally inaccurate in the documentation of the care that you provide to your patients. And guess what? Mistakes are going to happen. We are all human. I've made mistakes on calls. My partner has made mistakes on calls. The worst thing you can do is to try and cover it up. Um, few of the agencies that I work for have subscribed to the just culture model. If you don't know what it is, Google it. That's a just culture. And essentially what that means is that um, you are being very upfront and forthright about any problems that occur in the treatment of a patient, in the way that a call went. If you were to back into a pole and it doesn't look like there's any damage to your vehicle, or maybe there's just a small dent, but you don't think anybody will notice. Not failing to report that is not good. So being upfront and reporting something like that, even if it seems relatively minor, to make sure that you are being forthright. And the flip side of that is that an agency that follows the just culture model will not discipline you as long as you are acting with good intentions, and we're not doing something that was dishonest or unethical when the mistake occurred. So it's kind of a two-part thing there. But you never want to change a patient care report or a special report or anything unless you are actually correcting an error in your patient care report. So you made a legitimate error in how you document it, doing something, you can fix that. Okay, let's talk about consent. There's going to be a couple slides on this, and it's very important to understand consent because this is how we actually essentially have permission to take care of our patients. It's not something that you can automatically assume, and it's not something that you should assume without actually getting it. So you have to obtain consent in order to take care of any of your patients. Most often this is going to be done in the form of express consent, meaning that someone has called 911, you've responded out there to take care of them, they actually directly tell you that they would like you to take care of them. And when you go and introduce yourself and ask them why they called 911 and they start to provide you information about medically what's going on, that's essentially express consent, that they are there, they're telling you what's wrong, and there's an expectation there that they want you to start taking care of them. In order for somebody to give express consent, they have to be of legal age. So they have to be at least 18, they have to be an adult, and they have to be able to make a rational decision, which you can then probably make a joke or two about who can actually make a rational decision. And there's a way we evaluate that, and the person has to be what we call alert and oriented times 4 or by 4, and that means they're alert and oriented to person, place, time, and event. And we're going to cover the evaluation of a patient's mental status a little bit later on when we get into the actual assessment and care of patients. But they have to be able to make a rational, informed medical decision in order to give you express consent or any kind of consent at all. Another type of consent is implied consent, and so this is when a patient does not specifically refuse emergency care. And the example that I can give you in this is somebody that is unconscious or unresponsive. You're dispatched to a motor vehicle accident with unknown injuries. You arrive on scene, you find the driver of one of the vehicles to be unconscious. It is implied that a reasonable person would want to receive medical treatment for whatever has happened to them, whether they're injured or suffered a medical emergency, and maybe they're diabetic, maybe they're having a stroke or a heart attack, and that's what led to the accident. But they would like you to take care of them. Are they able to tell you specifically that they would like that or that they would not like that? No, but we're uh, running under the assumption or the implication that that person would want to have emergency care at that point. Another situation in which implied consent applies is when we think about minors. So we talked about only adults, people over 18 can give you consent in the form of expressed or direct consent. Minors, however, cannot. And by definition, as a minor in Pennsylvania, uh, we talked about as anybody that is under the age of 18. The exception there is that they have and can produce documentation that they are an emancipated minor. The other exception is that they themselves are a parent at an age less than 18. So you have a 17-year-old minor who has a child. Well, that person, by default, there is able to give consent for both themselves and for their child. Under the law, any other minors are not considered capable of speaking for themselves. And the other situation in Pennsylvania in which this holds up for us, and I deal with this up in State College quite a bit, is college students who are away at college, who may still be freshmen and 17 years old. They are living on their own. It's considered at that point, for our purposes, they can give consent. We do not have to call their parents at that point. So just some things for you to chew on there. Understand that minors, though, cannot give consent. So if you're called to a school bus crash, treatment of them falls under technically implied consent. The implication being that if you were not able to immediately reach a parent or a guardian, that any reasonable parent or guardian would want you to provide emergency medical care for their child in that situation. Otherwise, any kind of emergency treatment, you need to kind of wait until a legal guardian, that says patient, but it's just saying until a parent or legal guardian consents to the treatment. Now understand, though, if we're sitting on the side of Interstate 80 or 220 or a highway, and we've got a number of patients that we're trying to deal with, we can't wait for 20 minutes or 30 minutes to try and get in touch with mom or dad. We have to go about our business and carry that out. So if you cannot, in a short, reasonable amount of time, get that permission or consent from the parent or guardian, don't hesitate to start caring for that child. Again, you are protected in those situations. They fall under implied consent. Okay, so here's the gray area that we get into, and this is when we have patients that are altered in some way. And by I mean altered, meaning that they are not conscious, alert, and oriented by 4, meaning that they are not alert and oriented to person, place, time, or event. So there's a multitude of reasons as to why somebody could have an altered mental status. They could be under the influence of drugs, alcohol. They could have a legitimate medical emergency going on, in which case it's causing them to not be their normal selves. They could be suffering, again, from a stroke, from a diabetic emergency, from hypoxia, from acidosis. There's a litany of medical conditions that will produce an altered mental status. These patients cannot give you expressed consent. They cannot make an informed decision about their medical care. They cannot make that decision to refuse medical care. And in that situation, you have to step in and act in that patient's best medical interest. So if a person, appears to be a threat to themselves or others, if they are suicidal, if they've expressed suicidal thoughts, suicidal ideations, if they've expressed a plan, again, that person can't make a legitimate or an informed decision about their medical care. And we can talk more about this later on throughout the rest of class, but the other thing you need to understand is you have resources to help you here. Law enforcement, now I know it can be at times tough to come by out in the rural areas. However, in a situation in which you get into where you believe that a person is not legally able to um, refuse care or give you that expressed or direct consent that you need, and they are resistant to what you want to do, if you were to turn around and leave, that would be considered abandonment, which we'll talk about here shortly. If you need to involve law enforcement to help you compel that patient, you need to do that. The other option you have is medical command, getting in touch with a medical command physician at a facility to get orders to take that patient into protective custody in order to take care of them. So those are two options you have to get a patient who is not able to give you consent because of an altered mental status the care that they need. Not everybody wants to go to the hospital. In fact, most patients don't want to go to the hospital. A lot of times 911 is called for somebody that doesn't know that we were called for them, or we are simply called for some kind of medical evaluation on the patient. A person who is alert and oriented by 4, who can is able to refuse care. They are absolutely able to refuse care. Not everybody has to go to the hospital. We're not in the business of kidnapping people and taking them to the hospital. We have to, we can't do that. That's false imprisonment, but could be considered battery. We just can't do those things. So you can absolutely attempt to talk somebody into going to the hospital who has refused care and try and help him or her understand the consequences of refusing care. So you essentially need to explain what you want to do or why you feel that that person needs to go to the hospital, the reason that they need to go, the risks if they decide that they don't want to go, and that you can be blunt. You can be absolutely blunt with them. There's no need to sugarcoat it in any way, shape, or form. If you believe that that person's having chest pain and you believe that they may be having a heart attack, you need to spell it out for them black and white. Say, hey, there's a good possibility that you're having a heart attack. If you don't decide that you don't want any further care, if you don't want the ambulance or the MICU to continue in to transport you, understand there's a high likelihood that you're going to suffer continued serious illness, or you could die from this. Yeah, you can tell them that they could die. There's nothing wrong with that. Okay, sometimes that's what the person needs to hear to scare them, and for lack of a better word, into, or motivate them, that's probably a better word, into going to the hospital. Because the reality is, even as a paramedic, I'm not a doctor. I don't have any advanced diagnostic equipment beyond, an EKG machine, that I can tell what's going on with the patient. I can make educated guesses about what's going on, but again, I can't make a definitive diagnosis, and certainly EMTs and EMRs also have the same issue. So in order to mitigate the liability of them having some kind of medical care from you and then getting sick or dying later on, and a family coming back and saying, I'm going to sue, Beach Creek Ambulance or Fire Department because you didn't take my husband to the hospital when he was sick. Well, guess what? We have it documented that we explained that we thought he was sick and that he really needed to go, and that he understood that and didn't want to go. It's a huge area of liability for any emergency medical service agency, and it's very important that we not only explain these things because we want to take the best care of our patients as possible, but to cover both ourselves personally and our service for any liability legally that would happen if that person were to refuse and then get sicker or die. So we want to cover those areas. and I think we hit this here, but patient refusals absolutely need to be documented on whatever patient care record or that your agency is using. So most agencies use some variation of the standard Pennsylvania Department of Health EMS refusal form. Some agencies tweak it a little bit to whatever additional agency specific things that they agency specific policies that they have, but there needs to be a clear document, black and white, and the patient should get a copy of it for their own records, but you absolutely need to maintain a copy of it for your records, and it needs to go in your run sheet or your patient care report or whatever you're using at your agency, that there is a record of that patient refusing care. You need to have it. All right, let's talk about advanced directives. And we talked about this a little bit the other night. So an advanced directive is a document that specifies what a person would like done if they become incapacitated in some way. So they can't make their own medical decisions any longer. So in the event of a serious illness like a stroke, in which person goes into some kind of vegetative state or can no longer communicate their wishes for their medical care, there is some kind of pre-planning that's been done that outlines what that care or what care that person has wanted. And this comes in a couple of different forms. A living will is a document that will get drawn up jointly by a patient, a physician, and a lawyer. Sometimes the patient's next of kin are there as well. And they go through the different types of medical care that that person wants. And it's very specific as far as it's not just a do not resuscitate order. They go through all the different things like, do they want IV therapy? Do they want antibiotics? Do they want no CPR, but they would accept a breathing tube placed in their throat? What to do if they get into a vegetative state? Do they want the plug pulled on them? Do they want to live on a machine, or do they want to have that removed and pass peacefully? These things are all outlined in a living will. A lot of times this comes around when a person has been diagnosed with a terminal condition, a serious form of cancer or Alzheimer's, some kind of condition in which there's not going to be a recovery from that in the long term. A power of attorney, you've probably heard this term thrown around before, but a power of attorney for healthcare is essentially somebody that the patient has designated, and there's written documentation of this, that a patient is designated to make decisions about their medical care. So they may not outline everything in this living will, but they may designate this power of attorney to make these decisions about their care. This person may be referred to as the patient's healthcare agent or healthcare proxy, and they get to make the decisions about what kinds of treatment are done for the patient. Now, in order to do this, they need to actually have some documentation there that says they are, in fact, the power of attorney for that patient. Do not resuscitate order, DNR order, is something that, again, we talked about the other night, but it's essentially a written request giving permission to any medical personnel. This can be the staff at a nursing home, a doctor's office, a hospital, or in our case, emergency medical service providers, not to attempt a resuscitation in the event of cardiac arrest. So there will be no CPR, no ventilations, nothing that involve, no use of an AED, nothing that would involve working a code. Please understand that this is not a do not treat order. So if somebody has a DNR, that doesn't mean that we're not going to provide them basic medical care. That doesn't mean that we're not going to provide them transport to the hospital. A lot of times you're going to see this in patients who are elderly. They are already inpatient in a hospital or in a nursing home. They have some kind of terminal condition, like we talked about already, and they do not want CPR done. You must honor these. Even if you have a family member there that is crying and begging you to please do something for their family member, if there is a written documented DNR, that seems to be, clear and without question, legally, we are not to step in and provide care. And this can be, I will tell you from firsthand experience, a very, very difficult, stressful situation to go through on a call, unfortunately. So a lot of times the family doesn't have that documentation there, or the documentation that they have, you can't quickly legally verify it. This is a gray area. It's a challenging area, especially if you have somebody that is suffering cardiac arrest in front of you and there's a question about this. Um, when in doubt, begin the appropriate medical care. So if there's a question about the legality or the authenticity of a document or a DNR, you're getting conflicting information from family members, you will not be faulted as long as you can document that there was a clear question about the validity of something. You will not be faulted if you were to start care or such resuscitative care on that patient. Now, I've been in situations where we have done this, where we have started to provide a resuscitative effort on a patient. We've started CPR and gone through, using the cardiac monitor or the AED, and we're then able to, a short time later, confirm the validity of the DNR, or get in touch with a medical command physician or the patient's family physician who could help us confirm that we did not need to continue the resuscitative effort on the patient. So it's always better to start, and then you can always stop at a later time. However, if you fail to start the resuscitation and it turns out that you were supposed to, you can get yourself into a bind in doing that. So if there is a question, I don't like to speak in absolutes, but it would be extremely rare for you to have any kind of legal difficulties if there was a question and you started resuscitative care on that patient. Understand, too, I'm just going to hit this again, that the word of a family member, a friend, or other person is not a legal DNR. You need to actually have the legal written DNR in front of you, and there's a link there. I don't know if you can read that. Not, I will send that link out to you in an email that actually you can look at the form. And as I said, there's also a bracelet that the patient will wear, but should be an official form that has the Pennsylvania Department of Health logo on it for a DNR. These are the things that are actually considered a valid DNR. And when this stuff is set up with a social worker, with a lawyer or physician, all of this is explained to the family, and they are made to understand that if they cannot produce this document, or the patient does not have the appropriate bracelet on them, that EMS or any other healthcare provider is legally bound to start that medical care on that patient. So again, just to reiterate, you will not be faulted if there's some question of this at the onset of a resuscitation. I mentioned abandonment earlier. Abandonment is when you start care on someone, on a patient, and then you leave the patient before handing over care to another patient of an equal or higher level. So you can hand off care to another EMR, you could hand it off to an EMT on the ambulance it's going to be transporting, or a paramedic or a nurse, someone who is a higher level of care. And of course, you need to, in your documentation, document who, in fact, you're handing care off to. It's very important as well. If you do not do this, it is considered abandonment, and there absolutely are legal ramifications that come with that. This is something that you could, have your certification pulled over. Now, if somebody is refusing and they're competent to refuse, and you get a documented refusal of care, understand that is not abandonment. Okay, you treated the patient, they refused any further care or transportation on their own recognizance, you've documented it, you're fine. That's not abandonment. But if you go out to, a wreck, and you start to make contact with a patient and you talk about, medically what's going on with them, or they just want their blood pressure taken or something, and you turn around and leave, or there's a more serious patient and your whole crew goes over to that patient and nobody ever comes back to follow up with that first patient you were talking to, maybe they were a more minor injuries or whatever, and doesn't at least get documentation on a refusal, that technically is abandonment, and you could get into some trouble over that. So you need to be careful, and make sure that you're handing over care to somebody, again, equally or higher trained than you. There are some situations in which we can declare that a person is dead at the scene and request the coroner respond to the scene. If in the instance that there was any indication that the person is alive, you should begin providing care immediately. You can't make the assumption that somebody's dead unless some specific conditions exist. And these are essentially situations in which there's no compatibility with further life. So decapitation, in which the head is separated from the body. I would also add to that gross head trauma in which there is gray matter, basically the patient's brain has exited the skull, the cranial vault in some way, so they've smacked her head and you've got brain coming out of the skull. That is not going to be compatible with life. Rigor mortis is a stiffening of the muscles that occurs in a certain time period after death, and that's going to vary based upon the environment that the patient's in, whether it's a very cold, very warm environment. There's no set time in which that occurs. There's actually a range of time in which that can occur. But if you have somebody that is stiff, rigid, if they passed away in a seated position, and their arms and knees are still bent and they're not straightening, that's rigor mortis. Okay, that you're not coming back from that. That's where the term the stiff, you've heard a dead person referred to as a stiff before. That's where it comes from. Tissue decomposition. So if you actually start to have breakdown of cells, of tissue decaying, basically you start to rot, and that process, nature's a unstoppable machine that sets in pretty quickly after somebody has died. Within 24 hours, there starts to be significant tissue decomposition, especially in in an unchilled environment, and that's going to produce an odor and a lot of other unpleasant things. So if you're seeing that on your patient, don't try to start working a code, trying to bring them back. It ain't going to happen. Another one is called dependent lividity, and this is when all of the blood starts to pool to the lowest point in the patient's body. And when we say lowest point, if the person died in a seated position, you're going to see this dark purple reddish discoloration form in the feet and the ankles and in the buttocks. So wherever the lowest point in the body is, gravity is pulling the blood and fluids to that point. And again, that's a sure sign of death. You're not going to be able to bring that person back. And in fact, if you start to try and resuscitate that victim or move them, you're very likely tampering with a potential crime scene. Most out of hospital deaths are at least have some kind of very basic investigation done by your county's coroner's office, and if necessary, law enforcement is involved. If you are moving the body around or other things, you are contaminating that scene. So if any of those signs of death are present, that person's to be considered dead. Know what your protocols are for, like I said, requesting the coroner. it's important that you understand and know what your procedures are. And so every place is a little bit different. Over in Center County, we just contact our comm center via radio or phone and request the coroner be paged, and they'll send whichever coroner is on duty out to the scene. If it's an obvious situation where we believe that a criminal investigation is needed, we will notify whatever local police agency is responsible for that coverage area. All right, let's talk about negligence for a minute. Negligence occurs when a patient sustains some kind of injury or harm because the care that you administered was not up to par, did not meet standards. And it's actually a very specific legal definition, and in order to make a charge of negligence stick, and I don't mean that just in the criminal sense, but also in the civil sense as well. You may be not criminally negligent, but a person, could retain Edgar Snyder and decide to sue you in civil court for negligence. That's certainly a possibility. They have to meet all four of the conditions that are outlined on the slide here to meet the standard of negligence. So they must establish that there was in fact a duty to act. So nobody can come after you for negligence if you didn't actually have a duty to act. If this was a call that you weren't dispatched to, you're going to be in the clear. So there has to be an established duty to act. You in some way breached that duty, meaning that you failed to perform the actions that you should have done, whether that was by improper care or abandonment or just an absolute failure to even act and initiate care of the patient, that the patient suffered some kind of harm in this whole process, that they suffered further injury as a result, and that your failure to act or your improper actions were what actually caused their harm or injuries. So all four of those things have to be met. You had to act, you didn't act, or you acted incorrectly, the patient was harmed, and your actions were a direct cause of their injuries or their further harm. Confidentiality, we mentioned this the other night, but patient information is considered confidential. So this is to protect a person's individual privacy. So the circumstances of what happened, their medical history, whatever findings you came across on your physical exam of the patient, whatever care was rendered to them, that information can only be shared with other personnel, with other medical personnel that are in the chain of care for that patient. You can't go back to the station and share this information with everybody else that was there. You can discuss a call for educational purposes, as long as the specifics of the case and the identity and any other protected information are withheld. You can certainly discuss that, but you have a very fine line that you have to walk. So again, you're only going to be sharing this information with people, with medical personnel who are involved in the care of this patient. There is some circumstances in which you can release confidential information to individuals. Typically, a patient has to sign a written release authorizing that release of information. So if they wanted to go to a lawyer, or if you were subpoenaed for that information, you have to then turn around and provide it in a court case. There are certain sets of information that could be considered public information. And this is information, for example, that goes out over the air during the dispatch. So like the address of a call, the age, if a patient was transported, that isn't necessarily protected information. Now, whether that's up to your agency to decide they want to share that, it's up to them. Typically, what will happen is that a police agency or a fire agency may share that kind of basic information, especially when media requests it after a major incident. But information that was actually pertaining to their medical issues, their medical care, should not be released, especially to any media agency or placed on social media in the form of Facebook, Snapchat, Instagram, Twitter, any of these other social media platforms that are out there. That should not go to those things. And fire companies, when they post pictures after accidents, are really walking a fine line there and potentially putting themselves at risk. We mentioned HIPAA the other night. HIPAA was passed in 1996. It is a federal law that strengthens the protection of the privacy of healthcare information and helps keep patients' information confidential. Your agency, all medical agencies, are subject to HIPAA, and it provides the guidance that we have to follow on protected health information. Tells us how we have to protect that information, and it outlines what the penalties are for violations of protecting that information. The overwhelming majority of personal health information is considered protected and, again, should not be released without the patient's written permission. And a patient, even if they want their own information, must fill out and sign a written release. A verbal request is not acceptable, is not appropriate. If there's some question in your mind as to whether or not information is protected, don't release it to anyone other than those directly involved in the care of the patient. Again, that would be whoever's coming to transport the patient, or if you are involved in the transport, the nurse or doctor that you're handing care of the patient over to at the receiving facility. Every service is required to have a manual and privacy officer who can answer questions on this topic. If your agency doesn't, I suggest you go back to whoever your chief officer is and talk to them about it, because your agency can get into trouble for failing to comply with this aspect of HIPAA. You'll hear more about HIPAA, and any agency realistically should be giving you some set of basic training on HIPAA. It's a little lighthearted joke here about some of the trouble we can sometimes run into with HIPAA release forms. But again, just a reminder that patients have to release or have to sign a release form before any information can be shared. There are things out there called Good Samaritan laws. You may have heard of them at some point. Good Samaritan laws are there to protect private citizens from legal liability for any kind of errors or mistakes or oversight that is made in trying to provide emergency care, again, in good faith, trying to help somebody out who appears to be in an emergency. There's a lot of variability on Good Samaritan laws from state to state. Understand that as a EMR, as a first responder, and as a healthcare provider, the Good Samaritan laws realistically do not provide you much in the way of legal protection. Okay, you are considered a professional healthcare provider, a professional rescuer, kind of from this point forward. So you have to, make sure. Again, this is another reason to emphasize why you need to stay current on your skills and on your education, so that you're not exposed to situations in which you're making mistakes and somebody is, coming after you legally for that. Have some familiarity with the federal, state, any local or agency regulations that can affect your job. You have the responsibility of keeping your certifications current. That is not on somebody else, that is on you. There are things out there called reportable events. There are some situations in which emergency medical personnel are mandated reporters, which means that we have a legal obligation to report something that has occurred. The number one thing that I can tell you about is child abuse. You don't need to know that child abuse has happened But if you have a reasonable suspicion or there's some question in your mind, you have a legal responsibility beyond just an ethical or moral responsibility. You have a legal responsibility under Pennsylvania law to report child abuse. The interesting thing is that elder abuse is listed on this slide. Under Pennsylvania law, EMS is not considered a mandated reporter for elder abuse. We are considered an optional reporter. However, you know, you have to, sleep at night. So I would not want, that on my conscience. So I would seriously advocate making sure that you, if you suspect elder abuse, are reporting that. The other things that, are considered reportable crimes, any kind of violent acts, so knife wounds, assaults, gunshot wounds, there you this is an exception to that whole HIPAA area of sharing, protected information. These types of things legally should be reported. Also, motor vehicle crashes, sexual assaults, dog bites. Another one that people don't think about, is dog bites. Those have to be reported to the authorities. If there's an animal that is potentially a danger to other people, that needs to be addressed. Make sure that as far as crime scenes go, we've talked about this a little bit already, that a number of situations are also crime scenes. You want to minimize the contamination to these scenes. So if you determine that a crime scene is unsafe, pull out. Don't go in until law enforcement arrives and gives you that signal that the scene is safe for you to go in there. Our priority is patient care, but ahead of that, our priority is making sure that we are safe, our crew or our partner is safe, and then our patient safety comes after that. We are number one. Um, when you're sizing up a scene, document anything that would seem out of place or unusual. Maybe it's an odd smell that just doesn't seem right. Maybe you're seeing some kind of paraphernalia there, that for the manufacturing of drugs, you're seeing weapons that are there that seem out of place. Now I know this is rural Pennsylvania, and pretty much everybody out here's got firearms, and there's nothing that's particularly unusual about that. But if you're seeing any kind of weaponry that doesn't seem like it's the norm or the usual, if you're seeing some kind of materials that could be considered explosive devices or used in the manufacturing of those kind of things, that stuff is stuff that needs to be reported. When you're moving the patient, be careful that you don't disturb the scene. Try not to go in and touch everything, to knock stuff over, to move furniture around in these situations. Only do what is minimally necessary to provide appropriate care, good care for your patient, and get them out of where they're at so that we minimize the contamination of that crime scene. If the person's got a stab wound or a bullet hole, something in their clothing, and you need to cut the clothing off, please try and cut around it. Don't go through it. That kind of stuff can be used in a forensic analysis of a situation. You don't want to mess with evidence. Watch where you're putting equipment. You got to watch out that you're not putting it in a pool of blood, or if you're, I gave you guys the example the other night of the murder case I worked when we went in, and we weren't even, I don't want to say we weren't paying attention, but our attention was drawn to a victim in the corner and to a firearm and another weapon that were there, and we had inadvertently came into contact with some casings and kicked them. That's the kind of stuff that you will want to try to minimize, try to avoid when you go into a crime scene. Make sure you document it, and I talked about this too. Document what you saw, so that your memory, a couple days, even a couple hours after the incident, you're going to start to forget things. The sooner you can get stuff down on paper, or to get back to your station, to get on a computer and type out an incident report, the better off that you will be. Make sure that you're providing clear, appropriate documentation. Again, your documentation serves as the starting point in the chain of care for the patient. There's other purposes that come along with it, such as it being, the actual legal record of your treatment. If you didn't document it, it didn't happen in terms of treatment or care of the patient. You must document what you do. This is going to be a basis for evaluating the quality of the care that you provided. Good attributes of a patient care report include clear, concise, accurate, and readable. So if you've got rough handwriting, and I can tell you that some of you, from going through the email list that you provided me, some of you, your penmanship is not going to win any awards. So I would tell you that you need to be doing these on computers. And I'm not trying to make fun of you guys, because my handwriting is probably worse than all of you, but the point is that you need to make sure that you are providing clear documentation as to the care that occurred. Somebody down the road is going to pull up your care report and look at it, and it could be called into question. Things that you should document: condition of the patient when they were found, the description of whatever injury or illness that they gave you, or what you saw if the patient was not able to describe their illness to you. Vital signs: your first set and every repeat set of vital signs until you transfer of care must be documented. Any treatments that you provided. This could include splinting, immobilization, oxygen therapy, an ice pack, even. All of that stuff you want to document. Who you transferred care to. So, I transferred care to MICU 21, Goodwill, Jose LS, or whatever agency, whoever you're transferring care to, and preferably the name of the person that you transferred care to is important as well. Any patient medical history, medications, allergies, things you're going to learn about later on in class. Any potential infectious diseases or anything unusual at all with the patient. All of that should be documented. All right, so that wraps up Chapter 3. Hopefully this covered what you were looking for. Please make sure that you also read the chapter, and again, if you have any questions, Angie will be there on Tuesday night at class. I've already told her that I was going to be sending out this video. She'll be prepared to answer any more specific questions that you might have about Chapter 3. If there's something that I talked about here too that you don't understand, you don't want to wait to hear what Angie has to say on Tuesday, by all means, you can send me an email and I will try and answer your question as well. All right, thanks for watching, and I'll see you later this week.